Hello, professionals. This is Dr. Saad, and as you know, we are recording series of lecture for pharmacists who are going to appear for international equivalency exam. Today's topic is the last part of endocrine system, and we are going to conclude it as we was talking about the treatment of rheumatoid arthritis, and we was talking about the biological agent and tumor necrotic factor TNF inhibitors. And we was talking about the examples how we deploy them for the management of rheumatoid arthritis. So some points was remaining. So let's start from there. As you know that there is well established increase in risk of TB associated with TNFI. So conflicting data on role of TNIF and heart failure demonstrate a worsening moderate to severe heart failure. So it should be used with caution in patient with mild heart failure. And as you know that there's a New York Heart Association classes. It is divided into divided heart in four classes. That is class 1, 2, 3, 4. 1 or 2 are considered as a mild case. So in mild case, it should be used with caution. And but just keep in your mind that treatment with anti-TNF should be discontinued who develop a newer or worsening symptom of congestive heart failure. So be careful while using in a patient with tuberculosis as well as cardiovascular related risks or diseases. So this was all about the TNF inhibitors. Next is about the non-TNF inhibitors, non-TNF inhibitor biological medications. Their examples are abaccept, rituximab, tocilizumab, sarilumab, anakinra. So let's talk about it, their details. As you know that anakinra is administered once daily through subcutaneous route, and duration is weekly. And rituximab is administered 1000 mg through IV infusion with and the duration interval would be 2 weeks. It is said that the first dose the dose which you will administer at 0 week, the next dose would be at second week. Dose would be at second week. But keep in your mind that the rituximab shouldn't administer alone. It must be administered side by side, methylprednisolone, antihistamine, oral paracetamol along with each infusion. And response rate will appear within 16 to 24 weeks when you are administering this regime of rituximab. Next example is the tocilizumab. As you know that its dose is 162 mg through subcutaneous route once weekly or IV infusion with the rate of 8 mg per kg every 4 weeks. But keep in your mind that don't maximum dose is recommended is 800 mg through IV infusion, and but rate is 8 mg per kg every 4 week. This is about the example. This is about the tocilizumab. But keep another point which must need to kept in mind that this is recommended in those who have not received methotrexate or patient who have been intolerant to one or more CSDMRDs or tumor necrotic factor alpha. So a patient who haven't received methotrexate or who are intolerant to CSDMRDs or TNFI, tumor necrotic factor inhibitor drugs, in them tocilizumab is recommended with the dose of 160 mg subcutaneous route or 8 mg per kg every 4 weeks. Next drug is sarilumab. Its dose is 200 mg once every 2 weeks through subcutaneous injection, and dose reduction to 150 mg once every 2, or you can say it is recommended once every 2 weeks, and it is also recommended to omission or blockage of dose is recommended according to the neutrophil, platelet, and liver enzyme level. So if dose reduction is required, it should be done with the weekly duration. Like starting dose is 200 mg once every weekly, with the gap would be between two doses are 2 weeks, and dose reduction to 150 mg every second week according to the response of neutrophil, platelet, and liver enzyme. This was all about the siralumab. Abacept is a next example, and it is also administered through IV infusion according to the body weight. And as patient body weight is below 60 kg, then it is recommended to use 500 mg, or if patient's weight is between 60 to 100 kg, then it's recommended 750 mg, and if patient's weight is above 100 kg, then 1000 mg is recommended. And just keep in mind that IV infusion according to the weight, and the duration between the duration of administration would be that second and fourth week later than every fourth week after that. First dose would be administered at second, and then next dose would be administered at fourth week, and then after every fourth week, or after you can say monthly, it will be administered initially at second week and fourth week, and then after then every fourth week thereafter, alternative treat thereafter. This is all about the once monthly administration equivalent. So alternative dose is 125 mg through subcutaneous route at a weekly interval. It is also be administered. So just keep in your mind that Abacept is administered through the IV infusion, and its dose is according to the weight. And first and you can say dose will be followed monthly interval. So this was all about the non-TNF inhibitor biological medications. Next example is the target synthetic DMRDs. I will just mention its example here. That is the bari-ctinib and tofacitinib. And this topic, our topic of management of rheumatoid arthritis ends here. Now I will tell you about some guidelines that how we will use CSDMRDST and methotrexate and other medication under the principle. So keep in mind that initially UK, according to UK guideline, initially CSDMRDs plus short-term glucocorticoid is recommended. But on the other hand, EULAR guideline recommends the use of CSDMRDs as a monotherapy. Next is the NIC recommends a combination of methotrexate with either tumor necrotic factor inhibitor or non-tumor necrotic factor inhibitor. This NIC guideline recommends the combination of methotrexate with the TNFI or non-TNFIs. But where methotrexate is contraindicated or not tolerated, then monotherapy of above mentioned drug is used. Either combination with methotrexate, but once methotrexate is contraindicated, then monotherapy of TNFI or non-TNFI is used. This is according to NIC recommendation. But EULAR proposes that treatment escalate to the BDMRDs or to the TSDMRDs in combination with methotrexate. Once patient isn't responding to CSDMRDs, then EULAR guideline recommends to, instead of going for the T and tumor necrotic factor and non-tumor necrotic factor, just escalate to the BDMRD, biological disease modifying anti-rheumatoid drugs, or target synthetic disease modifying anti-rheumatoid drugs in combination with methotrexate. This is the recommendation of EULAR. Next is that EULAR guideline gives preference to the BDMRDs. EULAR guideline gives preference to the BDMRDs over target synthetic DMRDs. This was the next point about the guideline is that arthritis research. Yes, exactly. These are our guideline ends here. That this guideline just let us know that how we at which position will start CSDMRDs, glucocorticoid, biological agents, and target synthetic DMRDs. There are different recommendations. So according to your healthcare unit where you are serving, just follow their principles. But all guidelines have their own weightage according to the patient condition. If you want further study relevant to the rheumatoid arthritis, then go and see the website of Arthritis Research UK with further information available on their websites. So Arthritis Research UK website will give you further information relevant to the treatment. So I'm going to close my topic here, that is the rheumatoid arthritis, although it took too much time. So let's move on our next topic, that is the osteoarthritis. As you know that osteoarthritis is a degenerative disease of joint that most commonly affect the knee, hip, spine, small joint of the hand. So risk factor for the development of osteoarthritis include increasing age, obesity, gender, bone density, and joint injury, and occupational and genetics. So this is just brief introduction of osteoarthritis. Its management strategies, non-pharmaceutical management strategies are weight loss, structural education program, and supportive aids like wheelchair, and you can say, as I told you about the structural education program and exercise, then it is recommended to use 30-minute exercise per day in structural education program. And wheelchair, and people who wheelchair would be recommended in those people who have in those people whose osteoarthritis is mostly effective on their hip and knee joints. Next is the this was all about guideline from the non-pharmacological management. Next is the pharmacological management. So first line is paracetamol and topical non-steroidal anti-inflammatory drugs and oral non-NSAIDs are also first line of choice. Second is the opioid analgesics. ACR, the use of opioid analgesics. There are ACR guidelines that supports that the use of supports the use of tramadol but not other opioids. Just is ACR guidelines just supports the use of tramadol for the management of osteoarthritis as from the class of opioids, but not other opioids. So topical capsicum with the cream, topical capsaicin. There is a cream that is known as topical capsaicins, and its percentage is 0.025% cream. It is also recommended, and intra-articular corticosteroid injections are also administered for its management. Next is you can also use glucosamine and chondro sorry chondritis. Sorry, I am not pronouncing this word properly, so just keep in mind that glucosamine is also recommended for its management. Hyaluronic acid intra-articular injection. It is intra-articular injection is also one of the option. It is not approved in UK, and ACR guidelines support the use in people with older than 74-year age. For 74-year age. So although hyaluronic acid intra-articular injection is not recommended in UK, but ACR guidelines supports its use in people over 74-year age. So this was all about a brief introduction of the osteoarthritis, and our topic of endocrine system ends here. Now I just would like to let you know about the other class, that is the I would like to let you know that next topic of discussion would be chemotherapeutic agents, in which we will talk about antibiotics and virology and cancer and vaccines. And I would like to tell you one thing more, that DMRDs used in osteoarthritis. Sometimes it is also one of the options in the management of osteoarthritis. So if you feel that our video is helpful for you, then please support us by subscribing our channel, and see you in next video. And next topic would be chemotherapeutic agents. So if you want to get our organized lecture, then just go and check our playlist. All our recordings relevant to their system is organized, so you can easily find extract your required data.